Let's start Chapter 20, Part 2 of Immunologic Emergencies. So we've done our scene size up, our primary assessment, we've started our oxygen, made sure their airway is being maintained, decided this is a high priority patient. Now we need to get some of the history and some of the information about our patient, such as, what is the history of the present illness? What were they doing? Where might they have been exposed to an allergen? We're going to look at the additional signs and symptoms that maybe point us to this being an allergic reaction, possibly anaphylaxis. Are they sneezing or talk about a runny nose? Do they talk about tightness in their chest or throat? When they talk, are they hoarse? Hoarseness being a sign of irritation and inflammation at the vocal cords. What does their skin look like and their blood pressure? How's their pulse rate? How's their mental status? Do they talk about dizziness or itchy and watery eyes? All of those being additional signs and symptoms of an allergic reaction. Let's get a sample. Let's find out if they've ever had an allergic reaction. Do they have a history of having a reaction to something? Have they been diagnosed with an allergic reaction? Do they have an EpiPen? If they've had a reaction before, ask them, how does this compare? The more you're exposed to an allergen, the more serious a reaction becomes. So if this is only the first or second time they've had a reaction, it may not reach that level of anaphylaxis. However, if they've always been allergic or always reacted, then there's a huge concern and risk associated with being exposed to that allergen. Listen and ask about the foods that they've ingested, because that could be a sign of something that maybe they weren't allergic to before but are now. And then talk about whether or not they feel nausea or feel like they need to vomit. Let's do a physical examination. Let's look for whether or not they have signs and symptoms of swelling, hives, rashes, a reaction of some sort. Listen for the breath sounds at this point. Do you hear wheezing? We get a good, strong baseline vital signs, full set, pulse, respirations, blood pressure, pupils, and let's check out their oxygen saturation. Consider monitoring devices, making sure that you're looking at their pulse ox throughout the entire call. A drop in perfusion can be a sign of airway problems that are imminent. Listen to the patient. How are they breathing? How are they talking? And give that oxygen early. Repeat your vital signs every 5 minutes or every 10 to 15 if they're stable. Every 5 minutes, especially if they don't have a history or they're not quite severe enough to treat for anaphylaxis. We want to monitor, because it could be that they then end up in anaphylaxis. The longer we go where we can't treat it or where we don't have the right drugs, the greater the chance that this is going to become severe. Consider the need for additional interventions beyond oxygen. If this is a mild allergic reaction, then there really isn't quite the need for epinephrine. Mild reaction, somebody who maybe just has the rash and the itchiness, but not the respiratory distress, provide supportive care and transport them, monitoring them as you go. However, if this is a patient who is in respiratory distress with wheezing, hoarseness, coughing, difficulty breathing, altered mental status, all of those, then we're looking at the need to give epinephrine and to support their ventilations and transport them rapidly. Remember that you need to be able to document and communicate with the receiving facility why you chose to provide the care you did. What made you decide to give epinephrine, or what made you decide just to monitor the patient? Make sure you are documenting appropriately and giving a good report prior to your arrival at the hospital. So let's talk about that emergency care that we can provide in our immunologic emergencies. And that is when our patient is having a severe allergic reaction. So they're at that anaphylactic state and it's life-threatening. We start with our basic life support skills and transport to the hospital. We are providing ventilatory support, bagging, supplemental oxygen, and getting them to the hospital. That is the base of our treatment. If this is an allergic reaction as the result of a sting and the stinger is still present, we need to remove the stinger. Do not squeeze or use tweezers or forceps to pull the stinger from the skin because that can actually cause additional venom to be pushed into the patient's bloodstream. What you're going to do is take a stiff-edged object, such as a credit card or a driver's license, and push the stinger out of the skin from the direction it came. So you don't obviously want to push it in further, you want to push it out of the skin. And then we want to treat that area as an open wound. So we're going to wash it, and then we're going to consider removing any jewelry from the extremities. So if I've been stung on my arm, I'm going to take my rings off, because if there's swelling of the extremities, we don't want to see constriction caused by jewelry. We're going to put the injection site below the heart, so that we are allowing, hopefully gravity makes it a little harder for that venom to travel to the heart and then to the rest of the body. And we're going to apply ice or cold packs to the area to help with swelling. We do need to make sure that we are watching for those signs and symptoms of anaphylaxis, airway swelling, and severe respiratory distress. We're going to place the patient in a seated position, providing oxygen and monitoring their vital signs. If this is severe, if we are seeing respiratory distress, if our patient has a history and therefore has a prescribed EpiPen, then we can give epinephrine. And remember, epinephrine is just adrenaline. It is going to mimic that fight or flight response, which causes vasoconstriction. So that vasodilation is going to be reversed. Those wide blood vessels are going to be made smaller. It's going to increase cardiac contractility and ease bronchospasms. So what we get is when we give epinephrine, what we are expecting to see, the actions of the drug are vasoconstriction and bronchodilation. So our bronchioles and our bronchi will get bigger, easing the respiratory distress, and our blood vessels will get smaller, increasing our blood pressure and allowing the heart to work better. Epinephrine comes in an auto-injector pen. So as a BLS provider, you do not have to measure it out. There's no mixing a drug, no need to start an IV. We would prefer you assist the patient, but this is one of those drugs that if they are unconscious, we can actually give it as long as they meet the criteria. And obviously protocol may change. There is a push to see EpiPens be one of those drugs that we carry that do not require a prescription, but we're not quite there yet. This is an EpiPen. There is a safety cap. So the gray cap is your safety cap. It is retractable needle. So when you pull the pin out, you're not going to see the needle, not until you remove the safety cap and depress it against the patient. An adult EpiPen delivers 0.3 milligrams of epinephrine, so 0.3 milligrams. An infant or child EpiPen delivers half that dose, so 0.15 milligrams. So the adult comes pre-measured for 0.3 milligrams, and the child comes pre-measured for 0.15 milligrams. What are some of the side effects that we're going to see? So, obviously we're not exactly thrilled with some of these, but we do want to see them because it means the drug is working. And that's an increased blood pressure because of that vasoconstriction, increased pulse rate because we're improving the heart's contractility, anxiety because the heart will beat faster, maybe even a cardiac arrhythmia because it is a shot of adrenaline, pallor, so a change, a paleness in the skin, dizziness from the sudden change in blood pressure, possibly chest pain, a headache, nausea, and maybe even vomiting. So not all of those are pleasant, but they do show us that the drug is working. Why don't we give epinephrine? We don't give it to somebody who is not in respiratory distress or hypotensive because we do not want that patient to get the drug and then end up not needing it or needing more later. And then those who do not meet the criteria for a diagnosis of anaphylaxis. Epinephrine is for life-threatening emergency reactions, not for somebody who just has itchy skin and hives.